Hi everyone, I'm Dr. Duru Shah, the President of the PCOS Society of India, and you're watching the first episode of our program called Dialogue and Directions, featuring the International PCOS Guidelines 2023. We are all aware about the complex situation PCOS is, and its prevalence has been varied from 5% to almost 13-15%. On an average, we find that 1 out of 5 women in our country is having PCOS. And this is being mainly expressed either as a cosmetic or a fertility issue when women go to the various experts in the field. But in reality, we all know that it extends much beyond the upper layers of cosmetics. It is mainly linked to rising burden of various non-communicable diseases, especially diabetes, which is so prominent in our country, being one of the leading countries in the world with diabetes. And therefore, we must remember that PCOS is a diagnosis which needs to be addressed correctly. Currently, PCOS is also being related to cardiovascular risk, mainly because, and we know that diabetes itself is a risk factor, and hence we need to look at how we can reduce this risk in future for women with PCOS. There are long delays in diagnosis because women are going to different specialities for their different symptoms, and there's a long delay in the physician coming to a conclusion as to whether it is PCOS or not. And a whole lot of research has been put into this. And there's so much happening in the last few years that Professor Helena Teede, who is our guest today, has put together a whole lot of research together with evidence to show that whatever they are claiming in terms of recommendations has been completely evidence-based and with information which is correct. So this is something which we have to realize, that these guidelines have been made with assistance of various organizations involved, with hundreds of people working towards it. And we have had public health experts, we have had various disciplines coming in, we have had various organizations coming in, and I'm happy to say that PCOS Society of India has been one of them. So we today have decided to look at what really are the updates from the 2018 guidelines of PCOS, which were released in 2018. And 5 years later, in 2023, what else is happening and what are the new changes. So welcome, Helena, to our program, Dialogue and Directions. And I'm delighted to introduce Professor Helena to you. Helena is the director of Monash Center of Health Research and Implementation, Monash University, and professor of Women's Health. She's the lead investigator in the implementation and impact of this particular program. She's an honorary member of the Royal College of OBGYN. She's been appointed at Warwick and Birmingham Universities in UK, though she is in Australia, and she's a laureate of the US Endocrine Society. She has been the WHO chair of working groups and the president-elect of the International Society of Endocrinologists. She's also on the Council of Australian Health and Medical Science, and today top-ranked researcher in PCOS globally. She's on the lead of the International Guidelines for PCOS and executive director of Monash Partners. She has over 600 publications, and she's at the moment got $61 million in career grant funding. A world leader in PCOS, led the international guidelines, and a tremendous woman. It's such a spirit in her. I've known her for the past few years, and I truly am amazed with Professor Helena Teede. So welcome, Helena, to this meeting on the international guidelines, which you have led. And we are here today to see how we can be together and discuss what helped you to develop these guidelines, how did you proceed, what all did you do, and I think it will be a huge lesson for everyone to learn and get inspired by you to do even more. So first of all, I'd like to welcome you and thank you for being with us and spending your time with us. So my first question to you is, why did you think of developing the guidelines? And what was the process you followed in developing the guidelines both in 2018 and now in 2023?
Yeah, thanks. The journey to develop the guidelines, Duru, actually started with the patients we see in the clinic, where it was very clear that they were underserved, delayed diagnosis, multiple doctors before they got a diagnosis, and really dissatisfied with care. And indeed, our researchers showed that's the case around the world. And I think that was the first point. There was clearly an issue. We then got together all stakeholders in our country and asked them what sort of research we could do to help. And indeed, the response was research is great, but we just need guidelines because everyone does things differently. We have so many health professionals involved, and there's a lack of consistency. Now, the thing about guidelines is if you do them well, Duru, as you know, because you've been engaged here, is that there's a massive, massive amount of work to review all of the literature. And indeed, the latest guideline had a 6,000-page summary of the evidence and the meta-analyses and the new evidence that was generated by bringing all of that together. So it's a very big undertaking, and it's inappropriate for that to be replicated all over the world. The actual guideline recommendations, in all fairness, if they don't meet every country's needs, they can be adapted. But 90% of the work is in deciding what questions, and we went out to women around the world to decide that, and then went to our experts on the guideline panels, then actually doing the evidence synthesis and bringing that all together. So we're going to do that for one country. It's much better we do it around the world. And because this is such a controversial condition, it was really important that we brought everybody together. The other important thing is Australia is probably better situated in Asia than we are in Europe or the US. And we're in your similar time zones. I must say it's very pleasant doing this talk at my daytime instead of the middle of the night. But 60% of the world's population lives in Asia, and yet we see so often that the research and the guidelines really only reflect probably Western Europe and the US and maybe Australia. So our intention was to make these guidelines relevant to countries and world regions around the world, but therefore for us also relevant to our population, which has about 80 different ethnicities and diverse groups, and we're a very multicultural society. So for us, it was about being more inclusive and making sure all the disciplines were on board and doing the best job we possibly could. So 39 societies were involved, including Aspire and others, and they all put forward experts, including yourself, and also consumer groups who put forward experts and lived experience. We followed absolutely best practice, and at the moment it looks like, if things pan out as they will, that this will be the only ever guideline developed outside the UK, for example, that may be adopted by NICE, because it is incredibly rigorous and really there's nothing left undone. And so the 39 societies on board from all across the world have accepted those guidelines and endorsed them. And so you have now a very different starting point of consistency, of best quality evidence, and of clear priorities for research we need to undertake.
So yes, you did bring in so many organizations together and you put in so much of effort. It must have been a huge process trying to get everyone together, getting it funded, and putting everything together. So how much time did you take off from your work to do all that, and how much money did you collect to do it?
Yeah, look, the money was significant. I was successful in getting a Centre for Research Excellence, which is 2.5 million Australian dollars. And that is for research, capacity building, collaboration, and translations. It's perfect for this. These guidelines didn't cost anything like that. They cost around 250,000 or about just under 200,000 US, because most people's time is voluntary. And so we were really paying key people to bring the evidence together. But we also had contributions from major societies. So the US Endocrine Society, the European Endocrine Society, the American Society for Reproduction, and ESHRE all financially supported the initiative, which was far cheaper than if they had paid for it themselves. So partners helped contribute as well as the Australian government. The other thing that was very important is we then got substantial research translation grants, including a recent $3 million grant for some of the apps and translation programs, which are now used in 195 countries around the world. So we've had many different pots of funding. Yes. And the way we achieved that was really rigorous process, best practice, and strong engagement with consumers and with others. In terms of taking time off work, not a lot. I just incorporated it into my role. because I have a national funded fellowship, which is to do research and translation for impact. So this comes under that brief. So I do this work as a priority in my program. However, I did work incredibly hard, Duru, and much after hours work. And I did take a sabbatical for a number of months in which I completed this work. But I want to highlight that this was an incredible effort by a very large team, especially some of our early career researchers who just worked tirelessly on that massive evidence synthesis body of work, and also by many volunteer time by experts such as yourself around the world.
No, I could see the amount of work which happened when I was there, and it is really amazing to see how you all do it. And you wear so many hats all at the same time. You are a researcher, you're an academician, you're a women's health propagator, you're an activist, and also at the same time, you listen to make women's policy decisions with the government, with the federal government, advising them. So I think it's a huge task, and that's why I asked you, how much leave did you take?
Yeah, so not really leave. And on top of that, Duru, I'm a mother of two beautiful girls and have a wonderful partner. So I think, having said that, though, the reason I can do that is I have an amazing team. So that it's not a single effort by any chance. It is actually just an amazing team of people who enable that to be done in a huge voluntary effort. I think my contribution, to be honest, is bringing people together and enabling everyone to work collaboratively with really good governance and process and structure and a high degree of professionalism, so that once we do that, it just follows like a conveyor belt. And as my team becomes more and more attuned to this, for example, we've just basically co-led the premature ovarian insufficiency guidelines with Australian ASRM and IMS, and the infertility guidelines, unexplained infertility guidelines, which ESHRE led and we partnered in. So we've been able to replicate it. Now, they are much simpler than the PCOS guidelines.
Yes.
Because that is, PCOS is not just one problem, as we all know, it's much bigger. But, 2018 was step one, 2023, which is bigger than Ben-Hur, was step two. So it's incremental as well.
Yeah. So what did you add on into the 23 guidelines after 2018? What are the changes you brought?
Yeah, look, I think we got a little braver in 2023. And what I mean by that is we didn't just make health professional recommendations. This is a, lifelong chronic common condition. And as you mentioned, in India, incredibly common. And the challenge is, while it's called polycystic ovary syndrome, we will never be able to make really major headway. There are no true epithelial line cysts here. There are follicles that are half developed, and it's not a primary ovarian disease, and it persists after menopause. And so, and it looks like there's a polygenic version in males. So one of the passionate things I'm now doing with my team, Duru, is we're working on changing the name of the condition, which 91% of patients and similar proportion of health professionals want to do, to recognise that genetically it's a reproductive metabolic syndrome and clinically the same. So whilst the actual name isn't determined yet, because the process is still underway, the fact they're going to change it pretty much is. So I think that's the first really important thing to acknowledge in this condition, that we need to change the name. The second thing is we got brave around recognising that, partly because of the name Duru, and I presume it's the same in India, most medical degrees spend 1, maybe 2 hours talking about PCOS in 5 years of education. Now, this is the most common women's health condition and affects 1 in 5 in India, 1 in 8 around the world, 140 million women, and we spend an hour in the gynecology section on the ovary talking about the condition. No wonder our doctors don't know enough and our women are not being diagnosed, and we're compartmentalising the condition. So we need to, the guidelines recommended really dramatically arcing up around recognition of the type of condition this is, and basically a requirement for education institutions to improve their broader understanding, both in undergraduate as well as postgraduate specialty and across the relevant disciplines. And I know you do a great job of this in India, but I think there's a lot more that can be done. We also made recommendations for funders around recognising this is neglected and has a fraction of the funding that it deserves based on burden of disease. And then finally for government and policymakers about the same thing. and supporting advocacy groups in their work in this space. So that was a different step, because it's not just about the clinical management. Then we recognised that doctors needed to be more knowledgeable about the broader features and be more holistic in their care, and probably that models of care were needing to be dedicated to PCOS. Information needs for women were strongly recognised, evidence-based information. I did my first TikTok recently, Duru, because most of the stuff out there that women are seeing are on TikTok and Instagram, and now we had 72,000 views in 24 hours. So, and that was about
on TikTok.
Yes, so it was on TikTok, and that was about busting myths. So I think we need to get our information to where women are taking. So with YouTube, TikTok, Instagram, if that's where the promoters of commercializers, products that don't have efficacy, if that's where they're out there marketing, then people like you and I need to be out there with good evidence-based information. In terms of the condition, we advanced the evidence on diagnosis. AMH is very much been prioritised here, and also being able to emphasise that we need to make sure that we use the diagnosis in serial steps in the algorithm for this condition. So I'll go back to that. One of the major changes in the condition was the diagnosis with the addition of AMH, or anti-Müllerian hormone levels. And in that case, what we're recommending is we must use the diagnosis algorithm. So that means that the first thing you do is take a history for irregular menstrual cycles. The second thing is you look for clinical hyperandrogenism. And if they're both present, you have the diagnosis with no other investigations needed other than tests for exclusion. Yeah, so we've got AMH, we've got the algorithm. So we do irregular cycles, clinical hyperandrogenism. If they don't have clinical hyperandrogenism, then we check for biochemical hyperandrogenism. Only with free androgen index and testosterone. We do not recommend DHEA or androstenedione because they're not specific enough. And then if they don't have one or other of hyperandrogenism or irregular cycles, only then for diagnosis do we need to do either an ultrasound or AMH. And that's only 30% of women with PCOS. So this is not if they're presenting with infertility and you need to investigate them. That's a different story. This is just for diagnosis. So in diagnosis, it's now far less women who need an ultrasound, and they could have AMH instead of an ultrasound. Adolescents, very importantly, should not have an ultrasound or an AMH level for diagnosis, because in fact it's not specific enough. It actually just shows pubertal transition, and we overdiagnose. So adolescents have to have irregular cycles and hyperandrogenism.
Yes. So yes, there have been so many changes which have come up, which based on the research which has happened between 2018 and 2023. And that is exactly what is being brought in these guidelines. And actually, we have been promoting the guidelines in the past. 2018 guidelines we had promoted all over India. We created the PCOS Society of India only because we felt that there was a need for people to know and focus on the subject. And you won't believe it, Helena, after we have initiated the PCOS Society of India and done 2 or 3 annual conferences wherein we have brought in all the experts, including sleep apnea, we have brought in liver problems, gut problems, etc., neural behavioral problems. I think everybody's caught on to PCOS. All the clinicians are having huge sessions related to PCOS. And I think I'm very happy to see that happening in India. It's really working well. And we have promoted.
I have to say you're doing a great job. In fact, I think that the recognition, not only the prevalence, but the recognition of the condition in India is stronger than in many countries. Indeed, for example, in Australia, endocrinologists still are not really attuned to the condition, even though it's an endocrine condition. And not all of the care requires gynecological input. But we've got a lot more work to do, especially with our primary care doctors around the world, not just in India.
So we need to promote to everyone, and including patients, we are reaching out to them. We've started a program which is reaching out to patients through a grant we have received. And for the last 9 months, we have been doing physical and virtual sessions with them. So that's bringing in quite a bit of data we are collecting from them, and we soon hopefully will have some information for you. So
that's brilliant. The one thing we really need from your patient groups, Duru, is their opinion on the name change. We think it would be really important not to make a change in the name without good patient input from all across Asia. So
Yes.
we'll make sure to share the link with you.
Yes, absolutely. We'll do that. So you've created the algorithms for doctors to understand how to treat the patient, and we have put up these algorithms on our website. We are linked to your website, so everyone can see through our website. They get onto your website, they get the algorithms. We have sent out the hard copies of the algorithms, but you also have made algorithms for patients. You've made something for patients, right? You've created an app. Would you like to speak about that?
Yeah. So with the patients, really important because they get misinformation everywhere. And part of the reason they seek that information is they often don't get holistic care from their doctors. They might get infertility care or lifestyle, or if they see the right person, or very rarely psychological care, but they don't get everything. And so they often will look for more information. So what we find is that they're a vulnerable population who are paying for treatments that are not effective and are falling prey, if you like, to unscrupulous commercial providers who basically provide misinformation. So the app was generated partly because there was a demand from the consumer groups. And the app is quite literally based on the top 95 questions that women with the condition around the world have. And so we've generated answers to all of those from the guideline, but that's a lot of information. So the beauty of the app really is it's free. It's on Google Play and Apple Store, and women can download it freely around the world, and they do in 195 countries. And then what they do is they put in the problem they're most worried about, which at one age might be acne, and another age might be diabetes, and another age might be infertility or pregnancy or diabetes. And that information will be filtered up out of all of the information in the app. It'll be filtered up for them. There's also trackers in there, so they can track their sleep, their cycles, their lifestyle on the app. And very soon, with the new grant that we have, there will be a lot more assistance and support in the app that will be interacting with the women around what sort of things they can actively do. It also helps them engage with their healthcare provider and helps them generate questions for their doctors. It answers most of their questions, and then, you know, what is a hormone, what is an androgen, and then it'll generate a question like, what is my hormone levels? And that question will go in a little box for when they see the doctor. So it's really designed to get much better interaction. There's also booklets, information, webinars, and that's been really important. Very soon we'll be reaching out to the consumer groups around offering more resources and information for them. For example, speakers if they need it. I know you do a great job in India, but they can't always reach that in other countries. And then the other thing is we're advocating very strongly for better education for their health professionals so women can access better care.
Absolutely. But do you have languages on your app?
Yeah, we do. I think fairly soon. So some are already there, but fairly soon we will have the top 15 languages, which include those relevant to India for resources, yes.
So that's what I wanted to bring out, that the app will have the languages also, and therefore women in India could use it rather than us, you know, replicating the same thing. It makes no sense. It's just good for us to use it if we have it in the languages which our community would use. So I think that's a very great advantage to us too. Now, I think we have talked about the app, we've talked about the algorithms, we've talked about the content of the guidelines. Is there anything else you would like to tell to our viewers? The viewers today are mainly our Indian physicians who are watching the program. And the details of each of these guidelines will be discussed with each of the other experts who have been part of the guidelines. So we have